So first, let's actually define what is quality of life. According to the World Health Organization, they define it as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. Now that's a very wordy and sort of high-level view of quality of life, and so I'd like to put it into more discrete or real-world terms that you can relate to. And so these list some of the dimensions of quality of life. So things like employment, education, safety, relationships, leisure, and a whole host of other, but I'm going to hone in on health. And so when we talk about health and quality of life, we use the phrase health-related quality of life. And that's defined as the health aspects of quality of life, focusing really on people's level of ability, their daily functioning, and their ability to experience a fulfilling life. And some factors that influence health-related quality of life are disease, like in this case, aplastic anemia, injury, impairment, health perceptions, healthcare and health treatments, and health policy. Now, as a researcher, when we talk about health-related quality of life research, it really strives to help people understand the quality of life impact of health, disease, and treatment. And in so doing, being better able to understand the potential benefits and risks. And when we talk about risks, that's often the symptoms and the functional impact and even life expectancy of a proposed treatment. And ultimately, this kind of research enables program developers and policymakers to better allocate resources. And I'll come back to that at the end of the talk. But ultimately, the goal of health-related quality of life research is to provide information that allows patients to live life more fully. So I just wanted to give a little rationale for why I thought it was important to investigate health-related quality of life in aplastic anemia. So some of you may know the disease-related symptoms that may impact quality of life, like fatigue from having a low blood cell count, isolation and fear due to the infection risk of having low white blood cells, and even anxiety and depression surrounding the diagnosis and all the other factors that go into the treatment. There's also treatment-related toxicity, and I've only listed a few here, but I know there are a number of others. So weight gain due to steroid treatment when you're receiving that ATG that Dr. Hanna talked about, or increased hair growth, which is a side effect of the cyclosporin that's used in our immune suppressive therapy and transplant regimens. This certainly can be very concerning, especially to young girls and women. And even Dr. Hanna mentioned our new agent, L-Trombopag, which has been associated with GI symptoms like nausea, vomiting, and just other GI discomfort. And so certainly all of those factors can weigh into a patient's quality of life, but then there are also caregiver-related concerns about decision-making and outcomes and other factors that in my experience have really been eye-opening and warranted better understanding so that we can better address these questions. And so when I experienced these findings, I immediately went to the literature to see, well, what do we know about quality of life in aplastic anemia? So actually there was a study out of Switzerland, a university there, that compared 155 patients on immune suppressive therapy, or IST, and for those of you who were not in the earlier talks, that is a regimen of anti-thymocyte globulin, or ATG, and cyclosporin. And they compared those individuals to 52 patients receiving a hematopoietic cell transplant, or a bone marrow transplant. The study actually included both adults and pediatric patients, so it ranged from ages 2 to 74. And what they did uniquely in this study was, in addition to your traditional outcomes of survival or event-free survival, which is living without relapse of your disease, they also defined a metric called the quality adjusted time without symptoms and toxicity. or what they call Q-twist. And when we describe Q-twist, it actually consists of various different time intervals, one of which includes time with treatment-related toxicity. Then they also looked at time without symptoms and toxicity, and that means being sort of completely in remission or free of disease, also free of medication, and without any events, any side effects or toxicity. And last but not least, they looked at time from treatment failure to death. And what they found in this study is that the outcomes for all those metrics, survival, event-free survival, and Q-twist, was similar after 15 years of study. They also did note that among their transplant patients, they saw longer periods free from symptoms. Then there was another study in 2011 that looked at multiple different centers across the country, and again had 152 patients, both adult and pediatrics, again a broader age range in 7 to 55 years. And they first analyzed some conditions that can certainly impact your quality of life, like the presence of chronic graft versus host disease, or GVHD, lung diseases, the development of malignancy or cancers, and hepatitis, or inflammation or infection of the liver. And among those 152 patients, they actually had 49 adults who completed a quality of life questionnaire called the short form 36, or SF36. And in completing that analysis, they found that these individuals had similar physical and mental function, educational status, work or school status, financial situation, or marital status. But what's striking was that these individuals had higher denial of life and health insurance. This finding was actually comparable to a larger study that looked at individuals who were transplanted for cancers. And they found in general that these individuals had poorer health, and that was described as having frequent musculoskeletal stiffness, weakness and joint swelling, as well as sexual problems. But they did not see any difference in terms of rates of hospitalization and marital satisfaction. But as I reported before, they did find the same finding of more denial of life and health insurance, which suggests that this finding is more specific to transplant in general than aplastic anemia. But nonetheless, these are limited studies. They're either not directly related to aplastic anemia as a population, or they're limited in numbers and sample size. So that leads to some work that we're currently doing. And sorry, my mouse hid from me, but with the transit trial. Oh, excuse me, I'm sorry. I should take a step back and also mention that based on this limited data that we had, the National Cancer Institute, the National Heart, Lung, and Blood Institute of the National Institutes of Health, and the Pediatric Bone Marrow Transplant Consortium had a conference looking at late effects and focusing in on health-related quality of life, functional status, and neurocognitive outcomes. And in their consensus statement, they identified sort of what I just described, that in particular, research in pediatric health-related quality of life after transplant was really lagging, and there wasn't a lot of data in comparison to adults. And that was in part because we didn't have a lot of questionnaires to actually look at quality of life in a pediatric subset. And of course, understanding children, we can only go to a certain age to even analyze those topics. We also had small numbers of affected patients participating in studies, and really, unfortunately, there didn't seem to be an interest in this topic at the time. And ultimately, what they felt was that direct and comprehensive physical function measures may actually help us identify problems before they've come to fruition and allow early intervention. They also noted that it was really important to study longer-term survivors, especially as this relates to neurocognitive function and the impacts we may see later. So as I alluded to, going forward with future trials, we actually are going to start looking at these questions. And I wanted to take a step back and look at the transit trial that Dr. Hunnett mentioned, or the unrelated donor transplant versus immune therapy in pediatric aplastic anemia trial. And I will give the caveat that, again, as a pediatrician, most of the subsequent slides in the talk will be related purely to pediatrics. So Dr. Hanna used this algorithm to point out and just reference the current paradigm with treatment. So in anyone under the age of 40, if you have a brother or sister that is a perfect match, we recommend going to match sibling donor transplant up front because that has the best outcomes. And that's depicted here and here. For those who do not have a full sibling or do not have a full sibling that's a match, the current guideline is to pursue with the immunosuppressive therapy. And depending on your age, that also could include L-trombopag. But what we're questioning with the transit trial is, should we move matched unrelated donor transplant up to this level of decision making? And that's in part because, as Dr. Hanna described, we're actually seeing improving outcomes in unrelated donor transplant that suggests that it's at least equivalent to immunosuppressive therapy. And that's the question of the transit trial. So again, I'm going to just briefly go through the transit trial because I know Dr. Hanna mentioned it before, but I'm also aware some of you may not have been in his session. So the transit trial was unique in that it was a collaboration between the North American Pediatric Aplastic Anemia Consortium, or NAPLAC, and the Blood and Marrow Transplant Clinical Trials Network, or BMT-CTN. NAPAC is actually a consortium of my colleagues. There's roughly 45 pediatric hematology programs that participate. And we all collaborate on both clinical care programs as well as research protocols like transit. While the BMT-CTN has a similar function in the transplant world, it was established in 2001 to create these national multi-center trials, especially in conditions where there are small numbers of patients, with the goal of addressing important issues in transplant. So from this collaboration, they did the initial phase 1 of transit, which was purely just to see if we could actually screen patients for inherited bone marrow failures that were causing their aplastic anemia, and identify a donor in a suitable time period to then get them to transplant. And also to investigate, would patients and families be willing to randomize to the different treatments. So the study was initially open at just 8 centers. Originally 67 patients consented for screening, and this is at the time of presentation before diagnosis was made. So of that, 10 were found to not actually have aplastic anemia. And of the remaining 57 patients, only 23 were randomized. And what you see below are the reasons why some did or did not randomize. 6 of which just weren't interested in randomization, and largely in part because those individuals, I think based on the information provided, decided they really wanted to go to one treatment or another. And in fact, it was pretty equal, the patients and families that wanted to pursue transplant versus immune suppressive therapy. We did identify a couple of patients that actually had low telomeres, which suggested an inherited bone marrow failure, and one patient who was just too sick to proceed with transplant. Also, as I alluded to in the treatment algorithm, if you had a sibling donor, therefore you should pursue that treatment as well. So 11 of those patients exited the study and had sibling donor transplants. While unfortunately, we also had 7 patients who just did not have a unrelated donor available in the bone marrow transplant registry to proceed with the unrelated transplant option. And here we just again highlighting the treatment of the individuals who had immunosuppressive therapy. 3 actually failed and ultimately pursued transplant later. One of those responded poorly to transplant, but is still alive to date. And amongst those who were transplanted, all are surviving. At the time of this data, there was a follow-up of 1.5 years, but I believe Dr. Hanna may have presented more detailed data. The majority of these patients were able to get transplanted quickly within 34 days, with at least one outlier at a 70-day mark, but the range was really in a 20 to 50-day window. Of those that were transplanted, only one had rejection, and that was ultimately rescued by a second transplant. And then, as Dr. Hanna mentioned, and I spoke about before, we worry about graft versus host disease, or GVHD, when you're talking about unrelated transplant. But what we saw here was only a small number of patients developed acute or chronic graft versus host disease. And when they did, it was a very mild form and therefore very low risk. So conclusions for this study were that this approach was successful. We were able to screen 40%, or excuse me, enroll 40% of the patients that were screened. We have very few patients that went from transplant, were randomized to transplant and wanted to pursue immune suppressive therapy. We were able to get that time to transplant under 5 weeks. And as I stated, the outcomes of the transplant were quite good, with no extensive chronic graft versus host disease, and actually less than expected rejection or transplant-related mortality. So as a result, we are moving this trial to the next phase, a phase 3 trial, which now transitions to from looking at, is it even feasible to do this study, but is it effective to do this study, and will we have good survival and other outcomes? But importantly, we're actually adding quality of life as a secondary outcome for the study. So currently, my colleague and I, through the NAPAC consortium, actually have an open pilot study looking at health-related quality of life in children with aplastic anemia. It's open at 16 centers. And it's all via online platform. Our providers at the centers just give the patients and families information about the study, and they're consented and enrolled and complete the surveys all online. And I just wanted to highlight a couple of excerpts because this is ongoing data or ongoing research, so I can't share a lot of the data about people's perspectives on participating in the survey. So one patient and family actually said, participating in this study has really shown me how things have changed throughout the course of my treatment. Another younger patient admitted that he couldn't wait to do his surveys because he looked forward to getting the gift card at the end. And certainly that is a little enticement, but if that's making the patient happy, then I'm okay with that. And so, as I alluded to, this pilot study, given its success to date, will then be included into the Transit Phase 3 trial, of which Drs. David Williams and Michael Pulsifer are the primary investigators, and myself and my colleague, Dr. Mitch Niaki at Michigan, are the co-PIs on the quality of life aim. And here's just a brief overview of some of the instruments that we're using to look at quality of life in this study. So first is the PROMISE short forms, and PROMISE is out of the National Institute of Health. It's the Patient Reported Outcome Measurement Information System, and it looks at various thresholds of quality of life, including mental health, and subdivided into anger, anxiety, and depression. It also looks at physical health, in particular fatigue, mobility, which are important in our patients with aplastic anemia, as well as what we call pain interference, which is, does pain interfere with your daily activities? We're also investigating cognitive function and social health, and in particular looking at peer relationships. We're also using a different quality of life measure, the Pediatric Quality of Life 4.0, and in particular focusing in on that measures transplant module on self-image, which, as I alluded to before, certainly the consequence of these treatments can have a huge impact on self-image. We're also investigating reproductive concerns, which are quite important in our transplant population, but also we really haven't studied well reproductive outcomes after immunosuppressive therapy for aplastic anemia. And finally, we're investigating financial burden, which really looks at how does the illness impact your household income, your resources, and the like. And last but not least, looking at your healthcare utilization in terms of hospitalization, visits, and et cetera. And I just wanted to just give you a little pictorial of some of these measures so you have a better sense of the kinds of questions we're asking. So this is from the PROMISE measure. So it starts off with just general questions about your health, your mood, ability to have fun with friends. In our pediatric patients, we inquire about parents, interaction with parents, and then you see some questions about fatigue and sleep. From the PEDS QL, they're comparable questions, again, about fatigue and other sort of symptomatology. This is from the transplant module, which again has some of the similar questions about depression and anxiety. But if you see in the middle here, they ask specific questions about perceived physical appearance, whether, you know, for our transplant patients who may or may not have had a central line placed and may have scars associated, they ask about not liking other people to see their scars, or worrying about medicines changing the way they look, or being embarrassed when other people see them. And those are important things to know, which certainly I think you can acknowledge children would not readily share with their providers or even their parents at times. And then last but not least, I wanted to show you some of the questions that we ask in our financial hardship survey. Now, this survey is actually a 38-question survey that was modified from an instrument that was used to survey adults with cancers that were transplanted. And the survey is largely, of course, to be completed by parents, given it's related to the household income. But it inquires about types of insurance, whether that's public or private. It also even asks about difficulty paying for certain costs, whether that's transportation to and from appointments, or whether that's disease-related changes at home. Sometimes, you know, we're required to clean the home differently, or have special food for patients, and other circumstances that may weigh into that. And then lastly, looking at ability to pay for services to care for other family members, whether that's other children, or if the caregiver is actually caring for their parents at the same time. We also inquire about difficulty paying bills, medical bills or otherwise, or even if the treatment and things are making life more difficult and stressful. And again, this gets at information that patients and families may not readily share, but certainly have an impact on quality of life and our ability as providers to give them adequate care if they're having difficulty with resources. So in conclusion, I just want to say that highlight that unfortunately the existing data is limited, and that's in large part by sample size and focus on the disease. But I truly believe that the findings of this work will guide future research to focus on looking forward and assessing the differences in treatment along outcomes that really patients and families consider important. And lastly, I think the results will inform future patient caregiver education, allocation of resources, in particular as it relates to financial hardship, and health policy. And ultimately, the goal of all of this work is for us to help improve the lives of our patients and families. And with that, I'd like to open up for discussion and questions.
Thank you so much, Dr. Arnold. Are there particular questions or concerns that pediatric patients discuss with you regarding their quality of life? Are there some common themes or topics or things that you could share that would be helpful?
Sure. So for those of you who've been through treatment of aplastic anemia, you know, in the beginning is really the hardest part. And that's in large part because you're suffering from the symptoms related to your low blood count. So really it's the fatigue that is the biggest complaint, at least the complaint to us as providers. And just the inability to do activities that they're usually able to do. What we're starting to see with some of the data, though, is we're not appreciating the fear and anxiety that comes up with that initial diagnosis. You know, I think everyone wants to know that they can be cured and that they will survive this illness. But that fear and anxiety is really important in those phases, and being able to address that as a provider is important. Also, we are seeing that as the treatment goes on, these symptoms often abate. And so usually around 6 months from therapy, patients are starting to recover their counts, they're feeling better. They may even be engaging in society a little bit more. So we're seeing, in some ways, an improvement in quality of life there. Like I said, the study is still in its early phases. And so what we really need to see is how that changes over the long term, also looking at neurocognitive assessments and reproductive assessments. And unfortunately, being able to look at patients who may relapse or not fully respond to therapy and be able to assess that. I will say we at least have one patient who was treatment refractory, and we sort of see this bimodal peak in depressive symptoms that they endorse.
Thank you. Is there any data about infertility impact in transplant for non-malignant disorders, such as sickle cell or other disorders?
Yes, there's actually wonderful data out there, some of which my colleague Lillian Meacham has been involved with and published on, as well as Lydia Pecker at Johns Hopkins, and a number. So there's a two-part answer to that, or actually maybe even three. We know that the conditioning regimens, or the chemotherapy that we give to prepare the body to receive the transplant, has a negative impact on your reproductive ability. And in fact, in girls can result in ovarian failure, and in boys can result in delayed puberty. That's why we as pediatricians, if we have patients who are going to transplant, we always, and especially for these conditions that are not cancerous, we always have them see our fertility specialists to offer fertility preserving techniques if needed. In terms of sickle cell, we also know whether it's due to the disease itself and the impact on the blood flow or the treatments that we use to treat sickle cell. We've actually found lower fertility rates and reproductive issues in a subset of patients with sickle cell. We also see that compounded with transplant. The other factor that may also be at play among patients who are receiving regular transfusions for their disease is that iron burden may actually be playing a role in causing infertility. So then you add that to the chemotherapy that they receive for transplant, and we do see lower fertility and gonadal failure amongst those populations. Now, how that relates again to aplastic anemia and even myelodysplastic syndrome is unclear at this time because it hasn't yet been studied. But that is part of what we're doing in the transit trial, is not only looking at quality of life measures as it relates to reproductive concerns, and in our adult cohort in the study looking at sexual function, we're also going to measure hormone function and our lab surrogates of reproductive ability to see what the impact is.
Thank you. What about siblings? Are there any studies looking at the impact on siblings, when their family member, when their sibling becomes ill?
So that's a great question, and I should have highlighted that as well. You know, unfortunately, we have been slow to study quality of life in patients, and, which then means we're even less prepared or have less data on not only caregivers, but also siblings. At least in some of the non-aplastic anemia related data, there is some suggestion of sibling burden and what they call sort of survivor's guilt if the sibling is a donor and there is a bad outcome of the transplant. There is less sort of known around the siblings' anxiety and fear with being a donor, regardless of the outcome of transplant. But I think that's a huge and important area to study, of which we don't do well. We do currently have a policy and practice that the siblings, when they come in for their donor evaluation, are evaluated by a provider who is completely separate from or is a different provider from the physician who is actually doing the transplant, to try and give that patient their own unique experience without the bias of the other provider. So at least that practice is an opportunity to try and get at some of these concerns. But to my knowledge, we're not currently formally assessing that, but we really should.
Thank you. And does different milestones during a child's life create a greater impact on their quality of life? For instance, transitioning into puberty, those type of milestones, does that provide further impact on a child's quality of life while they're undergoing treatment?
Yes, that's another great question. What we've seen in our adolescent and young adult population, a significant impact, because that's the age group, and how we define that age group varies, but it's sort of college age individuals where their appropriate development would be pursuing autonomy and independence from their family. And unfortunately, this illness then sort of is a backslide in their development in terms of being dependent on a caregiver during the course of illness. And so, at least in some, again, not aplastic anemia data, but in leukemia data and other malignancies, we're seeing that actually has a stronger impact on quality of life, because they're struggling with navigating how to retain their independence, but also be dependent on a caregiver. The other challenge we have, sort of understanding things developmentally, is in the really young individuals who develop aplastic anemia, so under 5. Some of our quality of life measures can't actually assess that group. If you imagine those individuals can't read, they often can't verbalize their emotions and feelings developmentally. And so that's another group that it's really unclear what the potential impact on their quality of life is. Ideally, we can do some retrospective work and look back at those individuals once they're years out from their transplant and have them better articulate their experience. Currently, we rely on the parents as what we call a proxy to describe the experiences of their child in that age group.
Thank you. And for pediatrics who are looking at transitioning to adult care, that can be a very difficult time for the patient and for the parents. Do you have any suggestions on how to make that process easier? Because that too can potentially impact quality of life.
Yes, and that's a great question. And another comment to that adolescent and young adult group is not only the developmental aspect, but just the logistical aspect of, do I stay with a pediatric provider or do I transition to adult? And if I do, who do I see? The tragedy that we face is that there are several adult oncologists, but there are not equal adult hematologists. And so we do often find difficulty transitioning just purely for access to care. And then also, if we are able to identify an adult provider, we have to put into place practices to prepare them for that transition to adult care. Fortunately, there are models with sickle cell and hemophilia and other chronic pediatric conditions that tell us sort of what are the skill sets that a patient needs in order to adequately transition to adult. I mean, they have to first be able to say, I had aplastic anemia. They need to say, I'm on these medications, and be able, or even be able to access their records to convey that information to a provider and have that sort of developmental understanding. They also have to be able to manage appointments and things of that sort in order to be able to adequately transition to adult provider. And so that's part of the assessment that we in our practice do before transitioning our patients to adult care.
And when should parents start that process of transition, preparing their child to get ready for, moving to adult care? What age, or how should parents sort of start that process?
That's a great question. Truly, the process starts at diagnosis. Now, that doesn't mean that the expectations are the same, but the process starts with having a conversation with your child and saying, well, what do you understand about your illness? What do you understand about what's going on with your body? And having those conversations so that over time, those conversations then become more detailed and maybe accurate in terms of the words that they're using. In fact, when I interact with patients and families, that's often a question that I will ask both parents and patients to ensure that they understand their care, and that as we transition, they're able to say, I have aplastic anemia. So there's really no defined age for that. In the younger groups, it's less sort of what do you understand about your care. It's more getting them to talk about how they're feeling and what they're experiencing. I think if we'd have to say a solid age where we would definitely want to start the transition process at, we would say 13. That's when you start doing the education. A lot of programs at age 18, you must go to an adult provider. Others have a gray area between 18 and 21. But for either of those models, if you start in 13, then that means that you've got several years of preparation and building those skill sets to lead to an adequate transition between 18 and 20.
Thank you. Can a patient be on immunosuppressive therapy for life?
So that is a slightly tricky question. So to be exact, no. When we talk about immunosuppressive therapy in the world of aplastic anemia, that is cyclosporin and ATG. And so generally the ATG is a limited infusion and short course, and the cyclosporin is gradually weaned off. Also, given the toxicities of cyclosporin, we would not want to keep someone on that medication for a lifetime. The tricky part to that question is with newer agents like L-trombopag, it is possible that someone could be on L-trombopag for life. We don't technically quantify that as immune suppressant. If you saw in the mock-up, it says immunosuppressive therapy plus or minus L-trombopag. L-trombopag is what we call in essence, a growth factor stimulant in the way it works. But some patients could be on L-trombopag for a lifetime. Some patients may require restarting cyclosporin, but again, we would not want to continue that indefinitely. And also in a subset of patients who are on, who have PNH or paroxysmal nocturnal hemoglobinuria, if those patients have evidence of hemolysis or thrombosis, then we may start them on a treatment called eculizumab, which does modulate the immune system, and those individuals would be on that medicine for a lifetime.
Thank you. And our last question, at what age do you tell your child what their diagnosis is? Like, is there an age? So if your child's diagnosed at 2, it may be more difficult to explain, but At what point do you discuss with your child their bone marrow failure disease?
So the specific language of aplastic anemia, they should know by age 13. What I describe the condition as is a bone marrow failure. And patients as young as 7, 8, 9 can understand that their bone marrow doesn't work and that they have a bone marrow failure. It's sort of a higher level concept to be able to understand aplastic anemia is a type of bone marrow failure. Younger than that, it's really a discussion around I have a sickness or I have an illness that, that can make me sick, that can make me bleed, that can make me feel tired. So it's sort of adjusting the diagnosis to the developmental stage of the child. And so that can happen as young as school age, so 4, 5, 6, to have those conversations. Anything earlier than that is just really not developmentally appropriate for them to know and understand. As I said, in the 2 to 5 range is really just, being able to get them to articulate, mom or dad, I'm tired, or mom or dad, I feel sick. And that's the only sort of developmentally appropriate response at that age.
Great. Well, thank you so much, Dr. Arnold, for sharing your time and your expertise with all of us today. If you would like to watch this session again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send them to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. This session will end, and you will need to rejoin the conference using the same Zoom link or call-in number provided in your registration or reminder email. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes the session. Thank you, Dr. Arnold.
Thank you.